Good afternoon. My big apologies for the delay. As I'm sure you have noticed, no transition time has been allowed between the two sessions. So it was a few minutes after 2 by the time the other people left the room. There's a lot of empty chairs in the front. It's feeling very lonely up here. So if you would like, come on to the front, and the interaction may be even better that way. I'm delighted to be chairing this session, which is titled The Digital Age and Sexual Health, Friend or Foe. And I'm also delighted to be co-chairing with Dr. Matthew Golden, who's a professor of medicine at the University of Washington in Seattle. And I think he basically directs anything and everything which has to do with STD prevention and treatment in Seattle. Our first speaker is going to be Dr. Brian Mustanski, who's a professor of medical social sciences at Northwestern University, and he's also the director of the Northwestern University Institute for Sexual and Gender Minority Health and Well-Being, and a co-director of the Third Coast Center for AIDS Research. The title of his talk is Integrating STI Self-Testing into an E-Health Prevention Program for Young MSM, the Keep It Up 2.0 trial. Brian?
Thank you. Can you hear me now? All right. Guess I should have known to push the button. Well, let me just begin by thanking Sevgi for organizing this symposium on technology and STIs and inviting me to participate. And as she mentioned, I'll be talking about one of my technology-based intervention programs called Keep It Up 2.0, and how we integrated sexually transmitted infection testing in the context of an e-health online intervention. Oops. So just to say I have no conflicts of interest to declare. I want to begin the talk by thanking the collaborators and the funders for the project, including Jeffrey Parsons at Hunter College, Dr. Patrick Sullivan from Emory University, Eli Rosenberg at Emory, my project director, Crystal Madkins, and the funding that we received from the National Institute of Drug Abuse and National Institute of Mental Health, and acknowledge the major contribution that the CDC Division of STD Prevention made to the project by supporting the STD testing that occurred in the intervention. Just to give a little bit of epidemiological background, something that many of you are probably familiar with already in this audience, on rates of STIs in men who have sex with men, which is the focus of the work that I do and really calls for the need for innovative approaches to reducing sexual risk behaviors in men who have sex with men. This is data from the CDC's STD surveillance network from 2015, which shows rates of syphilis, urethral, rectal, gonorrhea, and chlamydia. And in this particular data set, you actually see similar levels of rectal and urethral, gonorrhea, and chlamydia in the MSM population. I'll be talking a little bit about how our data shows some different patterns later, but you can see within this data also major differences by HIV status, with upwards of 16% of HIV positive MSM testing positive for rectal gonorrhea and chlamydia as well, and around 8% of HIV negative MSM testing positive for urethral or rectal gonorrhea or chlamydia. I'll talk a little bit about, in our data set, around the overlap of co-infection with both rectal and urethral STIs in our sample. The population that I focus on in my work is young men who have sex with men, and that's because they are one of the only risk groups in the United States that's showing an increase in the rate of HIV infections. So this is also data from the CDC from 2010 through 2014 in terms of the number of HIV diagnoses by age group. And within that period, there was a 10% increase in the rate of HIV diagnoses amongst 13 to 24-year-old men who have sex with men, men, and a 27% increase amongst 25 to 34-year-old men, which really drives the focus of the work that I do on HIV and STI prevention amongst young men who have sex with men. What I'm going to be talking about a little bit is the series of projects that have been called Keep It Up, which started with Keep It Up 1.0, which was a grant from the National Institutes of Mental Health to develop an e-health HIV prevention program for young men who have sex with men. And the way the Keep It Up intervention is designed is it's for young MSM when they come in for a HIV test at a community-based testing clinic. Upon receiving an HIV negative test result, they're invited to participate in the intervention, hence the name Keep It Up. The goal is for them to keep up their HIV negative status. And it's a behavioral e-health intervention that I'll show a little of the content of in a second. As I mentioned, we target young men who have sex with men because of the epidemiology, but also because there's a lack of interventions, a lack of evidence-based interventions that in the US specifically target young men who have sex with men. And we also couple it with HIV testing because we believe that HIV testing is one of those critical moments for delivering a prevention program. People are thinking about their status, they've had perhaps some anxiety about their behaviors and their status, and it can be a critical moment to influence behavior change. Keep It Up 1.0 was designed to establish the feasibility and preliminary efficacy and acceptability of the trial. The results of that study are published in AIDS and Behavior and demonstrated a significant reduction in the rate of condomless anal sex amongst the young men in the intervention arm, controlled to an active HIV/STI education arm. We then did an implementation of Keep It Up, which we call Keep It Up 1.5, which was funded by the Chicago Department of Public Health. And in that project, we implemented Keep It Up throughout the city of Chicago as a service project to reduce rates of HIV and STIs in young men who have sex with men. Those results are published in AIDS Education and Prevention, and we also showed significant improvements in HIV knowledge, significant reductions in condomless sex, and significant reductions in condom errors as a result of participating in the Keep It Up behavioral intervention. The data that I'm going to show you today comes from Keep It Up 2.0, which is the NIDA and NIMH-funded R01 to test the efficacy of Keep It Up in 3 cities with both behavioral and biomedical endpoints. It's one of the first e-health interventions conducted in the United States focused on HIV that actually has a biomedical endpoint of STI incidence. We also were recently funded by ViiV to implement Keep It Up as a service project in Jackson, Mississippi, and we're just getting underway with that as an opportunity to again examine how to implement an e-health intervention within the community. To give you a little overview of Keep It Up, it has 7 modules that people have to complete across at least 3 different time points. So they have to log in 3 times separately to get through the intervention. The first module is a healthy person, really is interviews with young men on the street in different community settings, talking about their identities, their connection to their communities and families, their romantic relationships, and thoughts about sexual health promotion, use of condoms, etc. When we moved to doing a 3-city intervention of Keep It Up, we had each city shoot their own videos using the same core messages, but interviewing local young men so that the young men who enrolled in that city would see young men who reflect themselves at the first start of the intervention. And it's an example of a way to modify an e-health intervention to make it local, to make it connected to the specific community versus delivering the same intervention, throughout the country. Module 2 focuses on hooking up on the internet and involves examples of young men chatting on websites, meeting partners. It addresses issues like how your mood and your feelings and your affect influence your risk behavior, how substance use influences your risk behavior. It also talks about symptoms of STIs. In the 3rd module, we have a video soap opera where we follow a cast of young men who are dating and forming relationships, and it really addresses the assumptions that people make about someone's HIV status or about monogamy within the relationship. The 4th module is a virtual reality bar club that the participants enter and interact with different characters. Again, it addresses the issues of assumptions people make about being able to tell someone's HIV status by the way they look, It also addresses the role of substance use in sexual risk-taking behaviors. The fifth module focuses on dating, the sixth module on healthy communication, and we end with an individualized goal-setting exercise for the participants. One of the things that you'll notice that's unique about the Keep It Up intervention is it's really designed around the different settings and experiences that young gay and bisexual men have in their lives. So module 1 is not, this is what HIV is and how it's transmitted. This is what STDs are and how they're transmitted. It's really designed around the settings and experiences of young men's lives, and then we embed those educational messages within that setting because we know context matters and that universal messages don't have the same impact as really delivering them in a way that represent the experiences of people in their lives. In the Keep It Up 2.0 randomized trial, we added a booster session at 3 and 6 months that really addressed the role of dating and relationships, considering condom discontinuation within a relationship, how you should think about the potential for discontinuing condom use. We talk about PrEP. We talk about regular HIV and STI testing. So now I'm going to share some information about the way that we incorporated STI testing for the first time in the Keep It Up 2.0 trial, which is, as I mentioned, a randomized control trial comparing the Keep It Up intervention to an HIV STI education program in 3 cities, Chicago, New York, and Atlanta, with diverse young men who have sex with men. The primary outcomes are the number of condomless sex acts and the, prevalence or incidence of STIs, urethral and rectal STIs that were funded through a supplement from NIDA as well as with the support of the CDC. So as I mentioned, the Keep It Up intervention is really designed for young men who just received a negative test result. And so the way that was designed is when a young man receives a negative test result at a clinic, the counselor briefly explains the Keep It Up intervention and gives them a tablet that shows a video about the intervention and asks them to screen for eligibility. If they screen eligible, they are then immediately emailed information about how to complete the baseline and enroll in the trial. If they're not eligible, they're offered opportunities to participate in other studies. We also, with some supplemental funding, added an additional group of participants that did at-home HIV testing using the FDA-approved at-home OraQuick HIV test. So for these participants, they never went to an in-person visit, never went and had a HIV testing in a community-based setting. Instead, we recruited them through geospatial networking apps and screened them as eligible and then mailed them a box that included the STI test as well as the HIV test. And they were required to upload a photo of the negative test result to confirm their negative status. And we enrolled 248 out of the 901 participants using this approach. To talk a little bit more about how we integrated STI testing into the study, the way it worked was participants completed the baseline assessment of baseline outcomes, assessment of baseline outcomes. When they completed that, they were then shipped a kit that included some instructions on how to self-collect a sample for STI testing. And I'll zoom in on those instructions. You can see the kit included a large box, which within that larger box was a box for them to return the collected samples. It included the swabs for rectal self-sampling and a sample collection kit for a urine specimen. They were given sort of a menu that they could roll out on their table that gave them step-by-step instructions, as you can see illustrated, for how to collect the samples, how to put them in the box, and return them for testing. They also had access, I should say, to a video that explained how to do the urine-based and rectal swabs so that if they had additional questions, they could watch the video. They also had support staff that they were available that they could call if they had any questions. Once the kits were shipped, participants sent them back to the CDC STD lab. We had an 89% return rate. Nearly 90% of the kits were returned. We only had a few participants who only returned one or the other. So we had 3 participants who only returned the rectal, 6 who only returned the urine, and the other nearly 10% that didn't return either. So they weren't they never received the package, they weren't interested in participating. But I think that's a very impressive return rate in terms of the effort of shipping the kits out, that 90% of the ones that were shipped out were returned back to the lab for testing. The CDC then performed the Aptima combo gonorrhea chlamydia assay on both the urine and rectal swab. We then reported the results back to the participant using an encrypted email that had a report of their STI results that included a letter that they could take to their doctor explaining that they were in a research study. If they tested positive, it included a letter that they could take to their doctor explaining that they were in a research study, providing the results so that they could receive treatment without having to be tested again. And the feedback that we heard from participants was that most doctors accepted that result and provided treatment instead of having to retest the participants. We did also call them to provide referrals to either free or low-cost treatment in their community, and we reported the results to the local health department. At the 3-month follow-up, we asked participants who self-reported having an STI whether they had received treatment, and approximately 85% of the participants who were STI positive reported receiving treatment for the STI within the 3-month follow-up window. As you can see, the sample that we recruited was quite diverse. It spanned the 18 to 29-year-old age range, which was the focus of our study, fairly evenly distributed across those ages. It was also very racially and ethnically diverse, with about 25% of the sample being Black, about a third of the sample being Latino. So it was very racially and ethnically diverse, which we believe that in-person recruitment at the HIV Test Counseling Center is a great way to break down some differences by race and enrollment status. Predominantly a gay sample, although also about 15% of the sample identified as bisexual. And they were evenly distributed by region within the United States. Here's the baseline STI results, which are actually in press at the journal Sexually Transmitted Diseases right now. As you can see, 13% of the sample tested positive for a rectal STI, either chlamydia or gonorrhea. 8% tested positive for rectal chlamydia, 5% for rectal gonorrhea. So the rates were higher for rectal chlamydia than rectal gonorrhea. The rates were much lower for urethral sexually transmitted infections, with only 3.4% of the participants testing positive for a urethral STI. So as you can see, there were much higher rates of rectal STIs than urethral STIs. There were also fairly low rates of co-infection. The majority of the participants who had an STI had either a rectal or a urethral STI. There were very low rates of co-infection. Finally, just to say a few brief words about the acceptability of the STI testing process. Overall, participants in the study reported that the acceptability of the intervention and the study itself was quite high. Retention through 1 year was very high in both of the arms, both the Keep It Up arm and the HIV Knowledge arm. At the end of the intervention, we asked participants for open-ended responses about what they liked and disliked about the intervention and the study and what suggestions they had for improvement. There were 19 participants who specifically commented on STI testing out of the 400 or so that were in the intervention arm. And this is an example quote: "I'm thankful for the at-home rectal testing. Without it, I would have never known about my STI. Most, if not all, places do not offer the rectal test." And that was something we heard consistently in follow-up interviews with participants. For most of our participants, this was the first time they ever had a rectal STI test. They didn't know that you could get STIs in the rectum. They had never been offered a rectal STI test by their doctor. So for most of them, this was the first time they ever received it. Of the 3 people who reported dislikes, one said he didn't know he needed to get an STI test. One said he wished he had more privacy carrying the specimen cup when he did in-person testing, and one wanted free treatment. As I mentioned, we have recently completed all the data collection on the trial, and the results of the intervention are currently under review in terms of the effects of the intervention through 1 year. I can say I'm quite happy about the results, but I can't share them at this point. I think the intervention shows the possibility of integrating self-testing into an e-health program. We're currently implementing Keep It Up 2.5 in Jackson, Mississippi, and exploring issues of implementation, and are about to start a stepped care strategy for teenage MSM that incorporates the Keep It Up intervention. So let me conclude by, again, thanking my funders, my project staff. You can follow our research on Twitter at Impact Program, and find more, and some of the content of the intervention is available on our website, impactprogram.org. Thank you.
Thank you, Brian. I know we are running a few minutes late, but we will take 2 questions if they can come really fast.
Okay. Christian Hoer from the Netherlands. Thank you very much for this introduction in a really nice intervention program. But one of the drawbacks, I think, is that you didn't take into account syphilis, for instance, and I imagine that it's quite an important infection as well. So how do you think about it?
Yeah, I think that's something that we hope to explore in a future iteration of the study. So we're just beginning a cohort study of young men who have sex with men in Chicago that we're currently doing rectal and urethral STI testing. We're about to add syphilis testing to that cohort study. We don't know that much about the incidence of syphilis in this population, so that cohort study will begin to allow us to get some information about the rates of syphilis in this group. Once we have that information, I think we could propose the addition of that as an outcome in a trial like this. It is a bit more complicated, though, in terms of obtaining blood samples through the mail.
Yes,
people have to do a finger prick or provide another way of providing a blood sample. So those of you who are working on diagnostic approaches for syphilis, please share any innovations with me.
Okay, thank you.
Hi, Inês Dourado from Brazil. Can you comment on disclosure, the issue of disclosure of getting a box in their residence? Any issues with that?
Yeah, so one of the things we did is we did call the participants to sort of confirm the address that they'd like the box shipped to before we shipped it. So they provided an address at enrollment, but then we called them again and said, you're going to receive this box in the mail. You know, can we help you track it so you know when it's arriving? Would you like to send it to a friend's house or an alternative address? So we really worked with the participants, and there were very few of them who were unable to provide a location where they felt like they could receive that box. These are 18 to 29-year-olds, so the majority of them are not living with their parents at this point. So obviously that would be a major concern with a younger population. We did do a survey with teenage MSM about the availability of receiving boxes like this for at-home STI testing, and there were a lot of concerns, as you would imagine. And so we haven't implemented something like this with teenagers yet. Thank you.
Thank you very much. So our next talk was originally going to be given by Lisa Hightow-Wiedemann from the University of North Carolina. Unfortunately, she was unable to attend the conference. And fortunately, Patrick Sullivan has graciously agreed to step in for her. So Patrick is a professor of epidemiology at Emory University, has really been a leader in HIV prevention and the use of e-health for HIV prevention MSM. Thank you, Patrick.
Thank you. And good afternoon. I'm happy today to talk to you about a newly forming research network for adolescent HIV prevention in the United States called the Adolescent Trials Network, or ATN. And particularly, I'm going to talk about one of the 3 centers within this Adolescent Trials Network that's called ITEC. And I'll tell you a little bit more about ITEC. Just for perspective, the Adolescent Trials Network focuses on young people aged 13 to 24, and this is a critical population in the U.S. epidemic. I'm going to show you some infographics that are from the website aidsview.org, which I'll highlight it again in a minute, where we produce map-based information, and this one's highlighting the impact of infections among youth in the United States, where more than 1 in 5 new HIV diagnoses in 2014 occurred among those aged 13 to 24. Among those young people, most of the new infections occur among gay and bisexual men. So those infections accounted for 80% of new infections among youth. And of those 80%, most of them occurred among young men of color. So our epidemic in the United States increasingly is focused, as Brian showed, on new diagnoses occurring in younger age groups, and particularly in young MSM of color. And so then all phases of the HIV prevention and care continuum have deficits. And in this case, this is illustrating that of youth aged 18 to 24 who are living with HIV, nearly half of them do not know they're infected. And this highlights the need for good HIV testing programs that focus on youth. These infographics are all youth-focused. I wanted to just point out that if you're interested in getting these kinds of infographics on our AIDSView.org website, you can sign up and we will notify you when there's these new depictions of statistics about the epidemic. So our Adolescent Trials Network is really formed of three major research centers. One is the ITEC, which I'll talk about today. Another is called CARES. This is a center that's based at the University of California, Los Angeles. And the third center is called Scale It Up, that's focused on implementation science and is led by Hunter College and Wayne State. Each of these centers have a set of research projects and also functions for management of studies, analysis, and our ITEC also has a technology core which focuses on the production of e-health interventions. So for the rest of this talk, I'm going to be talking just about our ITEC center and walk you through some of the research projects and the kind of work that we're doing. So the ITEC Center is led by Dr. Lisa Hightow-Weidman, who is here, and myself. Our goal of the ITEC is to lower the burden of HIV infection by developing and evaluating innovative, interdisciplinary research on technology-based interventions. And we're thinking both about the HIV prevention continuum, that is routine HIV testing, assessment of risk, provision of condoms, consideration of PrEP on the prevention continuum, and also the care continuum. So for some youth who are living with HIV, being diagnosed early, being linked to care, being prescribed antiretrovirals, remaining on those antiretrovirals, and achieving viral suppression in the target age range 15 to 24. So why do we focus on technology? Technology can facilitate the recruitment, retention, and engagement in HIV prevention and care interventions, especially for youth. In the United States, cell phone ownership is actually highest among the youngest age groups, and many young people get their internet access primarily through mobile phones. mHealth interventions can quickly reach scale in delivering prevention and care services by using platforms that are familiar to youth. These are often trusted sources of information for youth, and youth are operating within established social networks. So we like the idea of plugging into places where youth are already engaging with others and already spending time. And finally, these technologies really let us translate complex information into a context that's relevant for youth. Anonymity is important for youth as they're accessing new information. Social support is available through social networks, and it's developmentally important for youth to be able to get more real-time assessment and feedback and have some of the engaging kind of features that Brian talked about, diverse modes, some video, some interactive, and this is well suited to the developmental needs and interests of youth. So our ITEC is structured in this way. We have three cores, as I mentioned. There's a management core that really has to do with having study sites where our interventions are tested and operations. We have an analytic core that manages the overseeing the data management and the analysis of qualitative, quantitative, and cost data. And we have a technology core that helps develop mobile technologies, deals with mail-out laboratories, which I'll talk more about, managing participants and recruitment. And then we have a set of studies, which I'll talk about in some detail, and they all use this set of core resources. Our subject recruitment venues are situated in parts of the country that are heavily impacted. In this map of the United States, the shading represents the intensity of the HIV epidemic. It's also a map from AIDSView.org, and it illustrates that the cities that we've chosen really are in heavily impacted parts of the country. This is a depiction of the different parts of the HIV PrEP continuum and treatment continuum that are addressed by the studies within the ITAG. So HIV testing is the point of entry, either to the prevention continuum or the care continuum. And as you can see, 4 of our studies directly address increasing uptake of HIV testing. And then these dots depict this set of studies that focus largely on the care continuum, including PrEP adherence. The dots here have to do with linkage and access to care, and Thrive With Me focuses on antiretroviral medications and adherence. And then many of these studies also address important psychosocial variables, such as social support, self-efficacy, STIs, and substance use, or structural variables like navigating healthcare systems, stigma, and poverty. So this depicts the span of the studies that are within our center. So I'm just going to talk briefly about each of the interventions that we're working with. The first one is called My Choices. This is a mobile app that is built to increase HIV and STI testing and support PrEP uptake among young men who have sex with men. I'll actually talk more. Unfortunately, you get to hear from me in the next talk as well, where I'll talk about the app that is really the basis for My Choices. And this is a youth adaptation that includes functions like making and implementing a testing plan, finding service locations, in this case, to get HIV testing or PrEP evaluation. So that's called My Choices. The next study I'll highlight is Links. And what I think is interesting about My Choices and Links is that they both are aimed at increasing HIV and STI testing, helping young men assess their potential eligibility for PrEP and get linked into PrEP. But they take 2 different approaches. My Choices, which I showed you before, provides information and encourages young gay men to make a plan for HIV testing and suggests services to them and provides them with service locations. Links is an app that takes a different approach. Instead of being based on social cognitive theory, it's based on the IMB model, and it shows this risk gauge that's like a speedometer and shows higher risk in the darker red regions, so men can put in some information, see what their risk of acquiring HIV infection is, and then can ask some what-if scenarios. So what if I decreased my number of sex partners and the needle will move a little bit? What if I started PrEP? And what if I quit using methamphetamine and the needle goes all the way over? And so that's a different way of motivating behavior change. So we have these 2 apps. They're both being tested in small pilot studies. If they're both acceptable, we'll move forward and test them head-to-head against each other with outcomes of uptake of STI testing and PrEP. So the COMPARE trial is planned after these 2 pilots, and we'll compare these 2 approaches based on different behavioral theories with the same outcomes in young gay men. So P3 stands for Prepared, Protected, and Empowered. It's an app, the smartphone app that focuses on PrEP adherence. So this is for young MSM who have already been prescribed PrEP. And it uses social networking and game-based activities to improve uptake. So part of what you can see here is someone can decide when they want to take their Truvada by correlating with something else they do in the morning, like brushing your teeth, making coffee, opening Instagram, eating breakfast, and they can pair that up with a routine activity. And they also can track how well they've done with their medication history to get a visual depiction. And so this will be evaluated against standard of care. And finally, Youth Thrive, which is the other part of our initial set of apps, is a mobile app that is for young men who have sex with men who are living with HIV. And this is an app that is about adherence to antiretroviral therapy and is meant to promote engagement in care using peer-to-peer interaction, medication reminders through text messaging, self-monitoring mood, substance use, and how those things are associated with ART adherence, and then some tailored informational content. So we really have a lot of themes here that cut across, but primarily we're thinking about things like personalized risk assessments, tailoring the content to people and young men and what their needs are, electronic diaries, and incorporating things like geofencing in the My Choices app, where if men have said they want to be tested at a community-based organization and they carry their phone near a place to get tested, the app will actually let them know, you said you wanted to be tested and you're now near a place that offers that service. Do you want me to give you directions because you're already close to it? So these are some of the sort of cross-cutting technology components. We're also using a participant management system for these multi-site studies that tracks participants and gives us a structured way to monitor retention and to provide retention activities, automatically providing text messages, calendar invitations, and tracking phone contact, and lets us prioritize patients with delinquent visits. We're using other methodologic innovations like infrared matrix-assisted laser analysis of hair that allows us to visualize and quantify antiretroviral concentrations in the hair of young MSN on PrEP as a way of monitoring PrEP adherence. In terms of harmonization, one of the interesting things about apps is that in addition to the outcomes of HIV and STI testing, you develop a lot of data about just how young men interact with the apps. How often do they open them? How long do they spend on them? What paths do they take through the different features? And so we call this paradata, and it's really data about app usage. And so because we have all these different apps, we'll have a separate analytic component that looks at the metrics of how you measure app use. And how often you engage in the paths you take may well mediate or moderate how efficacious apps are. And so we'll be doing those kinds of analyses. And then we're also looking at cost analyses to think about what it would cost to scale up these interventions if they're proved to be efficacious. We work closely with youth, and we get input from youth in all of the cities where we work, as well as centrally at the ITech. So we have youth advisory councils and local youth advisory boards, and we think it's important to have input from the communities that will use the app in the development. When you develop a network like this, you always hope that with the different cores and the different apps and the different cities that the whole is greater than the sum of the parts. But I think it's also true in this case that our team has many great parts. And so this just represents some of the institutions that are participating either in terms of the development and the leadership of these scientific protocols or in terms of sites. And so we have a very robust group of great collaborators. And I'd encourage you, if you're interested, to visit our website, which is itechnetwork.org. And at itechnetwork.org, you can actually find descriptions of all the studies that I've mentioned. We'll be giving updates as research moves forward and publishing results. This is one of 3 centers that are funded under the Adolescent Trials Network that in all currently comprise 15 protocols and will comprise 22 youth-focused protocols within the next year. So if you're interested in adolescent HIV prevention and what's happening in terms of new protocols, our site is one great place to start, as well as the Scale It Up and CARES, which have separate websites. So I will stop. Thank you for your attention, and happy to answer questions about what I've talked about.
I think we have time for a couple of questions. Maybe I'll start though, Patrick. So that was a great presentation, very exciting work. I was wondering if you could explain a little, as you guys are developing these things, at what point do you consider capacity for scale up? And how do you incorporate that, since it's so much work to develop these apps and things?
So the question is about scale up and how we anticipate that. And I'll say that in the ATN network that Jeff Parsons' center really is focused on implementation science, but I think all of the 3 components are thinking about both costing and how we prepare materials as we do the trials in the event that they are efficacious. So I think compared to sort of one-off research studies that we have more infrastructure to consider issues of scaling. And part of that in the apps that we've developed has also been trying to work with health departments at the early phases to ask about how these activities might fit into what they do. I'll talk a bit more about this in the next talk. But I think considering the perspectives of health departments, like carefully collecting cost data, and then there's another whole world about implementation of these projects that thinks about where the technology would actually live. If it were scaled up, would it live within health departments? Would it live at some place like CDC? Would it live in a nonprofit? Would it live in a for-profit? And I think that those are areas that we really haven't reached yet.
So, other questions from the audience? If not,
Thank you, Patrick, and thank you for doing the next talk as well, which is titled The Role of STI Testing in a Mobile Prevention App Focused on HIV Prevention for Men Who Have Sex with Men.
Thank you
Patrick
again.
was supposed to present this particular.
I was supposed to do this. Thank you. So for the next talk, I'm going to talk about a project that has been developed over a number of years to address the issue of comprehensive HIV prevention for men who have sex with men. And in 2012, I had the good fortune to be able to work on a Lancet series summary of prevention. And the main conclusion of that review of literature and consultations with great experts in the field was the direction to move in a thought of comprehensive prevention, so that we really are thinking about HIV testing, but also social supports, also STI testing, also considering biomedical options, and providing all these things together so that you don't have to go to the STD clinic for your STD testing, or you go to a place for HIV testing that says you really should get tested for HIV, but we don't do that here. I think there's a call to be more integrated. And HIV prevention and STI prevention, are a natural pair in that there are important overlaps in the populations who need services. There are common interventions like condom promotion and sexual negotiation. There are common intervention providers in some cases. There are biological interactions, which I'll talk about more. And there are programmatic links. For example, getting a positive STI test should trigger discussion about pre-exposure prophylaxis for HIV, given the tight epidemiologic links between incident STIs and new HIV diagnoses. I just want to highlight this piece of biology, and Brian talked about the high prevalence of rectal STIs, but for gay men, rectal STIs we've always known are associated with new HIV infections. And I'm going to show you data from two sources. One is our cohort that we conducted in Atlanta called the Involvement Cohort. And in that cohort, we found that the hazard of HIV infection for men with a rectal STI was about 3.7 times greater. In epidemiologic terms, we would say that represents two things. One might be some biological risk of having an STI in terms of inflammation, but also that men who have a rectal STI had unprotected sex. Unprotected sex is a risk for HIV. And all that to say that through an analytic method, we were able to tease out what we thought was the attributable part of rectal STIs to HIV risk. So if you take out that piece of confounding, that men who had a rectal STI were about three times more likely to acquire HIV. And that led us to a calculation of population attributable fraction, which says that about 15% of new HIV infections could be prevented if we had no undiagnosed and untreated rectal STIs, which I think is a powerful number. And so I was very excited recently to see that Matt Golden's group and Lindsay Barbie did a completely separate study design, a case control study asking the same question, and they reported that the population attributable fraction of rectal STIs was 14%. So two different mechanisms, one in Seattle, one in Atlanta, and come up with the same answer. So rectal STIs are a key part of HIV prevention. And yet we know in the United States that men who have sex with men just generally don't participate in STI testing as much as would be recommended. So these are data from the American Men's Internet Survey that's led by Travis Sanchez at Emory, and show for 3 cycles with 10 to 12,000 men per cycle that if you look at all MSM, only 30 to 40% report any STI testing in the last year. And in the US, we have big racial ethnic disparities in HIV incidence. And here you see in the 2015-2016 cycle that about 40% of white men, about 50% of black MSM had tested in the prior year. So the question is, how do we get men to do STI testing, which we think is important for their sexual health in general and is important for HIV prevention? The gaps in services are even greater among rural US MSM. And so just looking at getting, for example, a gonorrhea or syphilis test, the green bars here are men who live in cities. And so that gets closer to 40% for gonorrhea. But for men who live in rural areas, uptake is even lower. So what are the strategies to improve STI testing among men who have sex with men? One is to diversify modes of testing. Brian started this discussion. I'll continue it, which is about things like mail-out testing technologies. We're working on mail-out PrEP monitoring that includes STI testing. We can try to integrate services into medical care so that when men go in, they routinely are just offered HIV testing each year. The problems with that are that in the United States, we have a substantial population of people who don't have insurance and aren't going for a primary health care visit every year. But also that men don't always tell their doctors that they have male sex partners. And so, for example, an indication for screening for rectal STIs, the doctor may not know to ask about that. And I think many providers, in fact, don't offer it. Another idea is to convert behavioral interventions to increased STI testing into self-service formats. And so Brian's example of Keep It Up is an example of taking a behavioral intervention, putting it online so that it can reach more people. And then what I'm going to talk about for the rest of this talk is to increase the use of self-service screenings and service referrals through an app called HealthMinder. So I just want to say a bit more about at-home STI testing. And so there are a number of models for this, but based on the model of self-specimen collection that Home Access uses, which is a finger stick and a dried blood spot with a mail-in specimen for HIV testing, our Center for AIDS Research has developed and supported the use of home STI collection kits. So these are mail-out kits like Brian showed you with instructions. We typically collect urine, rectal swabs, pharyngeal swabs, and also a finger prick blood sample that's put into a microtube, about 100 microliters. And we do urethral gonorrhea, chlamydia, rectal gonorrhea, chlamydia, pharyngeal aptema, and syphilis at a 1:4 dilution, which maybe we'll get questions or criticisms after this period, because I know that people aren't thrilled with that. But our thought is that if we have someone who's screening routinely who has a negative 1:4 RPR and a negative 1:4 RPR 3 months later and 6 months later, and then develops a positive one, that's meaningful. The problem is that men who initially have a positive 1:4 titer, we don't have enough blood in that small quantity to do a proper titer, and we have to refer them in to have a repeat RPR and a titer. But we feel like there's a good reason to reach the men that we can serve with this small quantity, and some will have to be referred for further follow-up. So I just want to mention, obviously, Brian talked about Keep It Up. Another study called 1,000 Strong that was done by Hunter College had about almost 1,300 men, of whom 83% returned their kits. Brian mentioned the high kit return rate. We have a PrEP home monitoring system at Emory where we've had 95% return of these STI kits. And so I think it's really acceptable. We had concerns that men wouldn't want to do the rectal swab. I think our concerns as researchers are greater than the concerns of the men that we asked to do this. And we also have very high submission of biologically quantity sufficient samples to be analyzed in the lab across a number of populations and studies. So I want to turn to talking about a comprehensive HIV prevention app that is packaged in a mobile app. and we've recently reported the results of the development and pilot study of this app. And I'm going to frame the behavioral theory here around STI testing, and I'll try and develop a little bit more for you the relationship with STI testing. But the idea of the HealthMinder app is based on social cognitive theory. So what we're trying to reinforce for men is goal setting. Sorry about this. I'm very confused by the pointer, but I'm getting it. Goal setting, so I've chosen a plan to test regularly for STIs. I've set a goal. Self-efficacy says I believe that I can accomplish that goal. I can make a plan and I can get myself tested regularly. Outcome expectations is if I stick to that plan for STI testing, I'm going to improve my health and I'm going to protect the health of my partners. And self-regulation says I can use things like reminders in my phone to help myself stick to this plan and take care of myself. And so we apply this same behavioral framework then to a number of behaviors, including regular STI testing, but also condom use and sexual partner number. This is a screenshot of the app. As you would expect, you have to use a PIN to get in if you go away from it. It helps men think about things like how they might want to be tested for HIV. And in this screen, they can order currently HIV home test kits and condoms. I'll talk about the expansion to STI testing in a moment. And these things are just delivered to their homes, and they can self-test or mail in a specimen as appropriate. In our pilot study, we enrolled 121 MSM in Atlanta and Seattle. These were all men who were HIV negative, and we recruited them through Facebook and through Grindr, which is a sort of social sexual networking app. And we just gave them the mobile app, asked them to use it for 4 months, and then at the end had them come back and report on their experiences. 99 of the 121 completed that post-app evaluation. So this is just the level of usage of some components of the app. And what I really want to focus on is the test planning and some of the HIV testing data, because at the time of the pilot, we did not implement the STI testing. So I think the HIV testing is a model here for how men use these services, and I'll tell you about, starting in a couple months, we'll be rolling out another version of this that includes STIs. But we had a pretty high uptake. Over 70% of men used a test planning, HIV test planning section of the app to make a plan to test regularly. And so we've now extended that in the programming to include planning for regular testing of STIs. As I'll show you, a number of them used the app to either find an HIV testing location and also used the ordering of HIV test kits to take it home. In terms of how men use the app, I want to emphasize this idea of ordering things through the app, ordering prevention commodities. And so on the first visit, overall half of men, 53%, ordered condoms on their first visit, and 64% ordered at least once during the 4-month pilot. A quarter of them ordered more than once. HIV test kits were ordered by over half of men at some point during the 4 months, and those HIV test kits that they ordered were either used to test themselves, a significant other, a friend, or an acquaintance. Over 3/4 of the kits got used at home. And in some other sort of preliminary evaluations, 80% of those who said they were dissatisfied with their current condoms, the app suggested, hey, if you don't like those condoms, you should try some other kinds. Most of them did order other condoms. Nearly 90% of those who ordered condoms, when we asked later, said they used the condoms that they ordered. If we looked at the people who ordered test kits and said, had you planned on getting another HIV test, 2/3 of the men who ordered test kits said that they didn't plan on being tested, but given the opportunity, they decided to go ahead and do it. There were about half of the users who, on the first survey, did not have a plan to test for HIV regularly. Of those, half of them had made a plan by the end of the 4-month period. And we also had a fair extent of PrEP starts. 9% of the PrEP-eligible men started PrEP within that 4-month window. So in terms of what's next for this app, we're very close to starting a study called M-Cubed, which is a cooperative agreement with CDC. It's the app that I showed you. We've added some short prevention messages and video content, and we've also added the distribution of STI test kits through the app so they'll be able to be ordered. This is in collaboration with the Division of STD Prevention. And our outcome is uptake of prevention services, including STI testing. We'll be piloting that in 3 cities starting next month and launching in October. I mentioned already the My Choices app in the previous talk, which is an adolescent-focused app, which is basically the app that I just showed you, tailored for adolescents in terms of language and cultural references, adding STI testing. We have a new RCT of the app that I just showed you that's focused on PrEP uptake, where the goal is to help men use all these services, but also to start PrEP. And then we're integrating the mobile STI testing and other features into a platform that supports remote PrEP, so men can, without ever going into a doctor, do their STI screening, their creatinine screening, be prescribed PrEP, and do the 3 and 6 monthly monitoring all at home. And this is primarily to address that gap that I showed you in access of prevention to services for men who live in rural areas that may not have a PrEP provider or may not have a provider who is implemented a practice of rectal STI screening. So the app that I've showed you today is actually feeding out into a number of different applications that are specific to youth, specific to PrEP emphasis, and focusing on the integration of STI testing. I just want to mention that our Emory Center for AIDS Research actually offers these mail-out STI kits as a service. We've set up a platform so that we send stocks of these kits to Amazon, which is in the United States and probably in many places in the world, people get Amazon boxes quite often. And so in terms of the concern about receiving these materials, they come in an Amazon branded box. They have a very efficient delivery system. Our CFAR does the laboratory processing of tests. The issues with this right now are the syphilis testing, which we only do at a 1:4 dilution. Men don't love collecting the finger stick and the microtube. It's their least favorite part. So I'd also like to call on our syphilis research friends that we would love a dried blood spot assay that would make the specimen collection easier. So I know that's a small wish list. And I've put our Emory CFAR website address on, so if you want the printed materials that we use for self-specimen collection, or you want to implement this, you can reach out to us and we provide this as a service. So I'll just end by talking about the opportunities. I think we should be considering an RCT of just distributing at-home STI test kits for gay men. We've recently completed a study with CDC called eStamp, which was a study of distributing home HIV test kits. 2,600 MSM study where we distributed HIV test kits to half. The other half we recommended should be tested. The results of that will be presented at IAS in 2 weeks. And as Brian said, I can't say anything about them. But I am looking forward to the end of July. So that will be exciting. There's also a question about what the uptake of this would be in different models. So we've been testing this with a mobile app. But what if we mail out kits? They're pretty low cost to assemble. What if we mail them out regularly to men who have had STIs in the past or who have sort of other interests? What if we let men pick them up at service providers so they can go to a CBO, pick up the kit, collect the specimens at home because they want to receive the results by text or electronically? So there's implementation questions. I'll quickly close by saying, what are the impacts if we could scale this up? And we know that about 1 in 6 or 1 in 7 HIV transmissions is attributable to rectal STIs, could be prevented if we didn't have undiagnosed rectal STIs. So what would it look like to scale up testing, and what would the impact be on HIV transmission? What would the impact be on PrEP indications? Meaning that being diagnosed with one of these STIs is an indication for PrEP. So it also might increase PrEP indications. And then we want, look forward to improved syphilis diagnostics to support mail-in screening. All right, so I'm just going to end with this great work done by my colleague Sam Janess, supported and in collaboration with DSTDP, that asked the question how PrEP implementation would impact STI transmission in the United States. Because when we implement PrEP, we're also implementing de facto an increased frequency of STI screening. So this is results of an agent-based model, and I'll just emphasize one panel of this that suggests that when you, even if you have behavioral risk compensation, even if men abandon condoms to some extent, that if you're screening for STIs once every 12 months as part of a PrEP program, that you actually overall decrease HIV incidence from, say, 4 or 5% to about 4%. If you increase the interval of that STI screening to every 6 months, the incidence drops to a little over 2%. If you increase the STI screening interval to every 3 months, that drops to about 1%. So this suggests even if there's some behavioral risk compensation associated with PrEP, that the STI screening components of PrEP will actually provide significant benefits in HIV reduction. So I will conclude by saying there are substantial gaps in STI screening among MSM, and I think we've shown that mobile apps in the model of HIV testing and in the implementations such as what Brian has showed can be used to provide screening planning, screening reminders, and distribution of at-home test kits. Men are willing to use at-home test kits for HIV and STIs. Linkage to treatment is possible, and as Brian showed, is high. PrEP indication and PrEP prescription are related to STI testing in both directions. So for men who get PrEP, they're going to get more regular STI screening. For men who get more regular STI screening, they're going to have an increased opportunity for PrEP indications. And finally, that the fates of STI, HIV, and PrEP are increasingly and inextricably linked, and the STI prevention is HIV prevention, and the other way around. So I'd like to thank our collaborators and our funders, and happy to take questions.
Patrick, that was fantastic, an impressive amount of work. We will have to do these questions very briefly because we were deciding not to take questions, actually.
Uh-oh.
Okay, very quick, incredible work. How do you see in terms of scaling up this technology to countries where disparities regarding education is so high?
So the question is about apps in countries where disparities and particularly education is different. I think there's quite a degree of tailoring both of the technology and of the content. And there can be a pretty, to me, the bones of this kind of system, which is we're helping people make a plan to test, they're getting reminders on their phone, and they can order stuff. Those can really be put through a number of pipelines. And so when we started doing similar work in South Africa, we were using text messaging. By the time we got our system set up, everybody had moved to WhatsApp. And so we migrated that content to WhatsApp. And as we're thinking about future work, the prevalence of smartphone ownership is now emerging. And so I think both in terms of educational levels, but also in terms of technology, we need to be focusing on what the core components of this are, not the app that we built. Because in 5 years, the app that we built will look like something different, and it'll be through glasses or in a chip in your brain. But the components, which are reminders, building self-efficacy, providing more options, I think those really translate across cultures.
So this is a great conversation. I'm sorry, I want to make sure that we give Dr. Muhammad time to give his talk. So thank you very much, Patrick. I think we need, maybe you can catch up with Patrick after his talk. Thank you. So our next speaker is Hamish Mohammed. Dr. Mohammed is the principal STI surveillance scientist in the HIV STI department of the National Infection Service of Public Health England. And thank you very much for being here.
Good afternoon. So in the first place, by way of introduction, as many of you are aware, many countries worldwide have reported increased reports of STIs such as gonorrhea among men who have sex with men. So this slide shows trends in gonorrhea diagnoses by gender in Europe, and we can clearly see that since 2007, there's been a steady increasing trend in gonorrhea diagnoses in MSM in the black line since that time. In England, over the last 10 years, there's been, among MSM again, a doubling in the number of cases of syphilis and a quadrupling of the number of cases of gonorrhea. So this does beg the question, why are we seeing these stark trends? So when we unpick the data in England, we do know that there's been an increase in the number of attendances at sexual health clinics. However, the increase in STIs by far outpaces the increase in attendances. Furthermore, we also know that we've rolled out more sensitive diagnostic testing through NATs, especially in reference to the change in gonorrhea treatment guidelines back in 2010. However, we anticipate that the initial effect of that improvement in testing would have leveled off by now. Thus, it does seem indicative that risky behaviors such as HIV seroadaptive behavior is playing a role, and there's evidence emerging to suggest that HIV-positive MSM often report more condomless anal intercourse partners. So I'll show you an example. This is data from a serial cross-sectional study performed at gay social venues in London, and it clearly shows a marked, significant increasing trend in both the median in pink and the mean in blue number of condomless anal intercourse partners in the last year. So again, that's really dramatic evidence to show an increase in risky behaviors over time. So when we think of how we meet partners online, we can use a means of different sources: websites, social media platforms, or the focus of this talk, geosocial networking apps. So again, as many of you are aware, the body of evidence among MSM and the role that these apps play is far more robust than that of heterosexuals. So the first question I'd like to attempt to address is, what role are these geosocial networking apps playing in terms of facilitating risky behaviors? So this is by no means exhaustive. I just have a few examples on this slide. The recent papers published do show, for example, among MSM in Hong Kong, sexual partnering via apps increases the likelihood of inconsistent condom use with casual partners. Furthermore, in Taiwan, app users were more likely to report condomless anal intercourse partners, and fairly consistent evidence from the US such that app users were more likely to report more recent partners or more lifetime partners. However, in this instance, there was no difference in terms of the number of condomless anal intercourse partners. So we have some evidence from the UK after an investigation into an outbreak of Shigella flexneri 3A among MSM that was first recognized in 2009. So the results of a semi-quantitative investigation unearthed a really interesting finding. HIV-positive men infected with Shigella were 19 times more likely than HIV-negative MSM to have used apps to facilitate condomless anal intercourse. So just tying this bit of the presentation together, there's evidence emerging that suggests that apps will facilitate high-risk sexual activities in MSM as expressed through a higher median number of sex partners, increased occurrences of condomless anal intercourse, and also there's a role in facilitating HIV seroadaptive behaviors. So now I'll transition swiftly. And again, as mentioned, there's a lot less evidence in terms of the role of apps in risk behaviors in heterosexuals. So the first example I wanted to discuss is a nationally representative cross-sectional study in 15 to 20-year-olds in Norway that found that there was a higher chlamydia prevalence in adolescent boys who used the internet to meet partners. However, amongst both boys and girls within that age group, those who used apps to meet partners for sex were more likely to have had more partners. Furthermore, they also had a higher chlamydia prevalence to those who only met partners offline. So an example from the UK again, this is from 2009, so it's a bit old. However, there was pretty clear evidence to suggest that there was higher rate in heterosexuals of condomless intercourse with HIV non-discordant casual partners in those who use the internet to look for sex. However, and this is an important point that the authors contend, there was no evidence to suggest that the internet as a venue in and of itself facilitated riskier sex. So in other words, internet users were just as likely to have condomless intercourse with partners met on or offline, which is a point I'd like to highlight. So just to synthesize this bit of the presentation, what we do know is that apps are facilitating high-risk sexual practices, such as increased number of partners, partnership concurrency, condomless intercourse, anal or otherwise, and HIV serosorting. However, what we do not know is whether apps only facilitate high-risk practices among risky individuals. So I'd just like you to bear that in mind. So at this point, I'd like to transition and talk a bit about the opportunity that exists through the usage of these geosocial networking apps. And I'll start by presenting a Lancet report published in 2014. And if you'll allow me to paraphrase, with today's advancements in smartphone technology, it's becoming increasingly important to ensure that health promotion messaging remains up to date with how communities engage. And I think the previous two speakers did an excellent job in terms of showing the opportunities that may exist. Now, do such messages currently exist across the plethora of geosocial networking apps geared towards gay men or heterosexuals? So there was a group that published a really interesting systematic review, having performed a search of the two most popular app stores for mobile phones. They used the search term dating and systematically reviewed the first 60 free results to assess whether they contained any sexual health content. So I won't take a show of hands to see how popular these safe sex messages were or were not, but only 9 out of 60 apps contained any sexual health information, such as pop-up messages encouraging STI screens or links to STI information. So there's definitely a gap that needs to be addressed there. Now, I'm also aware of the fact that this is a case of preaching to the converted, and I'm sure if I were to take a show of hands amongst yourselves, we would agree that, hopefully I'm not being too confident here, we would agree that an opportunity does exist to leverage the reach of these apps. However, are we barking up the wrong tree? Is it acceptable to use apps to push out or promote sexual health information? So there's one instance that shows promising results. This was an online survey of app users in North Carolina in the US among gay men. And in this study, the authors found that roughly 2/3 of the survey respondents found apps to be acceptable. However, there was a difference between those that found it acceptable and those who didn't, such that those who were more willing to receive sexual health promotion information via apps were more likely to be non-white, those unsure of their HIV status, or with a lower degree of HIV testing self-efficacy. So that's something to bear in mind. This is a chart from a syphilis outbreak investigation in rural Wales in 2013 into 2014. And just to orient you a bit, on the top there's an epidemic curve that shows the number of cases along this axis and time in months along the y-axis. So we see the outbreak progressing steadily with a peak in January of 2014, after which time the outbreak control team pushed out a variety of sexual health promotion messages via the most popular apps within that area. So they managed to deliver apps to just about 800 users. And as you'll see, it facilitated a precipitous decline in the number of syphilis cases. However, do interpret this with caution. This is purely a temporal correlation. The authors do not contend that the health promotion via apps was the sole cause of controlling the outbreak. It was, however, an important tool in the STI outbreak control toolkit, if you will. So again, further evidence from the United Kingdom, just to show some sexual health promotion campaigns, and I'll just draw your attention to the one in the middle. This was during Brighton HIV Testing Week, and there was a banner just to illustrate the risk of STIs in terms of their transmission orally, and this had a click-through rate of 7%, and I think we should really be quite optimistic about such high click-through rates. And just to put that in context, if the banner on the app or the website appeared 100 times, 7 people who use that page were likely to click through the app. And I think if you get a click-through rate above 3%, that's deemed to be fairly successful. So in this instance, it was quite high. So some data from the English HIV self-testing campaign from a couple of years ago. So just to orient you again, there are two bar charts on here, and these are the results of how people heard about the service, the HIV self-sampling service in England. And this is only among MSM, and I'll direct your attention to the slice of the pie in blue. So among the 20 individuals that had a reactive test result, 20% of them received information about the service using dating apps. And when we look at those with a non-reactive test result, 40% of those received information about the self-sampling service using dating apps. So again, this shows the potential of apps for this means of health promotion. So in summary, what I've tried to do is highlight the challenge that apps may present to us as public health professionals. So there's evidence to suggest that apps are playing a role, an increasingly prominent one at that, in facilitating high-risk encounters. It certainly is one of the most common ways to meet sex partners in modern times. In some population subgroups, apps may be facilitating high-risk practices. However, apps do present a golden opportunity for low-cost health promotion to a captive audience that is often difficult to reach through traditional health promotion messages or campaigns. So at this point, I'd like to thank you for your attention and thank the organizers for inviting me to speak. Thank you.
We have a few minutes for questions. We have a few minutes for questions. Sorry. I'll start with one. I'm interested in your thoughts. This is a problem we certainly have encountered in the United States. Is what do you think is the impact of this on partner notification for STIs and HIV when so many of the patients are meeting their sex partners on apps which don't consistently leave an easy trail to find the people again?
So Matt's posed a really challenging question, and I agree. If apps are facilitating numerous anonymous contacts with sex partners, it does present a challenge for traditional means of partner notification. I think in an instance such as those for outbreak investigations, you'd have to engage with these apps to push out health promotion messages, such as the syphilis outbreak investigation in Wales. So I think you are right, it is difficult to perform PN for anonymous contacts, but hopefully we could leverage the power and the reach of the apps to promote health promotion and the need to get tested.
Mm-hmm. Patrick?
So the reach of the self-testing campaign was impressive, almost 18,000 men. Can you say a little bit more about how that was promoted and rolled out, and was it a sort of a Public Health England function to provide that laboratory service? So I'm just interested how you reached that scale.
So this was, and again, I'm aware of the fact that the National HIV Self-Sampling Program Manager is sitting at the front of the room as well. So I'll try to do this justice. This was a collaborative endeavor between Public Health England and local government authorities in England. And it was done using an online campaign that was facilitated by a charity organization. So it was through a variety of different mechanisms, using a website, an actual campaign with posters on public transport venues during HIV testing week rather, and for the 2 months following that period.
Other questions? If not, I'll make one final comment. It seems to me that one of the real themes in this session is the emergence of the self-testing at the interface with the apps. That we really have a lot of evidence over more than a decade of not great consistent success with self-testing. We have the Dutch randomized controlled trial of chlamydial screening, which initially looked like it was going to go okay, and then it turned out the uptake of the intervention was not particularly good. It appeared to be better in Scandinavia in the Danish studies than it's been in some of the other studies. But I think what's new here and innovative is the interface with the apps, which allows for the communication to be automated. And so I think there's really a new opportunity to look at some of these studies which didn't turn out perfectly in the past and see whether they can't be improved upon. So I think it's very encouraging and exciting.
Oh, we have a question. Go right ahead.
I don't think this
Yeah.
is this on? Yes.
Yes.
Okay. Renata Sanders from Johns Hopkins in Baltimore. And I don't know if this is specific to you or to also Patrick and Brian. I really want to unpack a little bit what we think are the challenges to trying to pair STI testing, apps, mobile devices, mobile interventions, particularly for adolescents that are less than 18 years old, young men who have sex with men, and how we overcome some barriers, ethical barriers, informed consent, some other policy and structural barriers that may impact access for that particular population that we know is most at risk and have some of the highest rates. And that's for anyone really, but thank you.
Well, I guess, as maybe one of the only adolescent researchers on the panel, I'll try to tackle it. It's definitely a challenge, and we, in preparation for the application for that adaptive trial that I mentioned, which is it's a stepped care type intervention for adolescent MSM, we did some focus groups with young men about their ability to receive packages through the mail that would include STI tests or HIV tests. And there were some real challenges and real concerns raised by the young men about those packages being intercepted by their parents if they weren't out to their parents. So, that's definitely, I think, a concern that we have not identified an adequate solution to. We do a lot of focus groups with teenage young men who have sex with men. We have a lot of success, a long history of recruiting. At this point, I would say I've probably recruited thousands of teenage 14 to 17, 18-year-old gay and bisexual boys online through various research studies. So we know how to reach them. We know how to engage them in discussions. We know how to deliver web-based interventions to them. I haven't yet really resolved the question of how to deliver packages to them successfully. We did ask about questions like, could we ship it to a different location? Do you have a friendly relative or something who might want to receive it? And I think those would be options that we could explore more. But in my opinion, at least, we wouldn't be ready to go into the field with something like that until we did a lot more qualitative focus group research with the population to understand how to do it. And there may be a subgroup who that's viable for. And I think we would also need to understand that better.
Thank you, Brian. Our time is up. I'd like to thank all of you, a wonderful audience, and please join me in thanking our brilliant speakers one more time.